We are live now, doctors. You can start the session.
Okay, so a very good evening, everybody. I'm Dr. Sunandini Bose. I welcome you all for this session from Team YOSI and YOSI Career Portal. So, just a minute, sorry, my. Uh, so, in the year 2014, YOSI was founded by Dr. Tarun Arora and Dr. Vijay Sharma. It is now around 5,000 members strong. It is a society that supports and guides the YOs in their career and beyond. In the year 2022, the first time the PWG groups that we call were introduced and YOSI job portal was a part of it. And this is the current office bearers where Dr. Devakan Mishra is the president, Dr. Sonal Kalia is immediate past president, Dr. Karan Bhatia is vice president, Dr. Nilesh Kumar is secretary, Dr. Aditya Sethi is treasurer, and joint secretary is Dr. Prasanna V. Ramesh. And we have a executive committee of 20 ophthalmologists who are all young ophthalmologists. And in the month of end of February 2025, we had our first launch of the UC Career Portal app where you can post various fellowship datas and various job opportunities and you can shortlist candidates and we are in a area now where we are also introducing the iOS version for this the same. And in the consecutive months, we started doing our webinars. In the first month, we had a webinar, the first launch webinar, where it was graced by the AISC, AIS Governing Council. And subsequently, we had a few webinars on fellowship, and then we had a webinar on to plan your dream clinic. And we coming to the today's webinar, that is the foundation of private retina practice from vision to reality. So I welcome our chairperson, Dr. Satyaprakash Tiwari, sir. He is a veterinary surgeon of more than 10 years of experience in the field of retina and eye care. He has done his MBBS from prestigious PMCH with a gold medal, and after that he did his MS ophthalmology from Kanpur. He's also trained in field of retina from Arvind Eye Hospital, Pondicherry, and from the year of 2013 he has been serving in the field of retina in Patna and Bihar, and currently the director of Dishtipunj Eye Hospital, Patna. I also welcome our chairperson, Dr. Piyush Bansal. Dr. Piyush Bansal is an chairperson of Scientific Committee Maharashtra Ophthalmological Society, also the member scientific committee for AIOS, executive committee member for BRSI. Is currently the director of Bansal Eye Institute, Pune. He has completed his MBBS and MS and further done a long-term fellowship from Venu Eye Institute and LV Prasad Eye Institute. And he also holds degrees of fellowship for FICU and FRCS. He has more than 18 years experience as consultant ophthalmologist and vitreoretinal surgeon, has an experience of more than 51,000 complex surgery, eye surgeries. In the academic world, he has numerous national and international publications and routinely practice in private sector, have been serving the area of Maharashtra since then. I welcome my co-moderator, Dr. Nilesh Kumar, who is the current secretary of Young Ophthalmology Society of India, also the medical director of Madhvi Netralaya Ara. He is an he is an executive editor for iQuest also and the chairperson for Communication Retina Rocks Retina World Congress and also the convener for TSTC at AIC 2021 till now. He has more than 100 plus papers and invited lectures in various international and international conferences and more than 90 plus peer-reviewed published articles. I'm Dr. Sunandini Bose. I'm the team lead for Career Portal app and also the executive member for UOC. I'm also the section editors for various journals in India, and I'm an executive member for IMA Janakpuri, and I'm in cataract cornea and refractive surgery. So I welcome our speakers, Dr. Pratik Kakkar and Dr. Devakan Mishra. Dr. Pratik Kakkar is an esteemed ophthalmologist in New Delhi. He also holds a master's degree from AIMS New Delhi and over 11 years experience as a retina specialist. And he has various degrees in his hand as DNB ophthalmology, FICO, FICO, and the distinction of being a gold medalist as a senior resident. He is also known as his meticulous approach and precision in performing various eye surgeries, including retina surgeries, cataract surgeries, LASIK, and retinal detachment surgeries. I welcome our second speaker, Dr. Devakan Mishra, who is currently the president of YOSI and also the director of Swarna Jyoti Eye Hospital, Aliganj, Lucknow. He is also the head of retina services, Swarna Jyoti Eye Hospital, Aliganj, Lucknow. I welcome our panelist, Dr. Kshitij Raizada. He is a vitreoretina surgeon and pastor from PGIMSR and ESI Hospital, New Delhi, and done his MBBS from New Delhi. He is currently working at Dr. Raizada Eye Center. Bareilly has been awarded second prize in the EVRS in Budapest and awarded International Ophthalmic Hero of India in AIS at 2025. He is an active participant of AR, ASRS, EVRS, and various other national and international conferences. I welcome our panelist, Dr. Pranav Saluja. He is a vitreoretina surgeon from Lucknow. He has done a senior residency from MLN Medical College, Allahabad, vitreoretina and UVA ROP fellowship from Sadhguru Netra Chikitsalayah, Chitrakoot. And he was also the consultant at Sadhguru Netra Chikitsalayah, and he is currently the executive member of UP State Ophthalmology Society, assistant editor of YO2 YOSI, and currently working as an associate consultant at Center for Sight, Prayagraj. And I welcome our panelist, Dr. Anand Bhosle sir. He is the director and consultant at Vijay Netra Seva Super Speciality Eye Hospital, Kolhapur. He has a dual fellowship trained in Arvind Eye Hospital, Coimbatore, and Sir Charles Hospital, Perth. He has more than 15 international publications and two book chapters to his credit, with many more than 15 invited guest lectures and numerous awards at national and international levels. Thank you, everybody. So, with this, I hand over the podium to Dr. Nilesh for starting the first talk and inviting the speakers.
Thank you so much, ma'am. So before we start, I think we'll take a quick word from both of our chairpersons about what is the need of having this webinar. Like, how do you start your retina practice? Is this a relevant topic today? So, both Dr. Tiwari sir and Dr. Piyush sir.
This topic is extremely relevant nowadays because, see, retina practice, to start retina practice is a very complex thing. We need a lot of instruments and a lot of range, like various range of cost of instruments are available. Like vitrectomy machine, cost of vitrectomy machine may range from 15 to 20 lakhs up to 2 to 3 crores also. Likewise, lasers, OCT, angiography, then other portfolio. Starting retina practice is not as simple as a cataract surgery practice. So to guide the youngsters so that they can start their practice with a minimum of investment, and slowly they can build their practice, and as they grow their practice they can add more instruments. So in initial phase of retina practice you need a lot of guidance, and webinars like this are going to help a lot to youngsters. Once they are established and they are earning a lot, then there is no uh, like stopping. They can achieve or they can acquire whatever they want. But in initial phase, guidance from this kind of webinar is very, very crucial to the youngsters.
Thank you so much, sir. And Dr. Piyush sir, your comments.
So before I can make comments about this webinar, I'd like to first congratulate the entire team. A fantastic concept. I've been following all the work that UCB has been doing. Big kudos to the entire office, especially to Dr. Devikant Misra and Dr. Naresh Kumar. But to Sunandi, thank you for inviting me to be over here. It's a very relevant program. So thinking back when I started my practice just around 10 years back, of course, stepping out of a fellowship and then gradually jumping into private practice directly, I've made my own mistakes, and it's our duty to share those, kind of improvements in thought process. It's not just about the money, I think. It's about the thought process that comes in trying to make a calculated decision of what is going to be useful in the beginning, and knowing that, say for example, certain investigations might not be revenue generating, but those instruments perhaps are going to help you in better clinic patient satisfaction and outcomes. So having that kind of mindset is very important, and this is the right medium perhaps to influence not just younger minds, I would say, even as we become more senior in practice. It could be 10 years, it could be 20 years. You have younger surgeons, say for example, even look at YOSI, the kind of programs that you are coming out with. So the programs are innovative, they're new, they are tackling the problems that are faced by, so to speak, younger ophthalmologists. But it's the senior ophthalmologists also who need to learn from all of this, because times are going to keep changing. We need to keep adapting, And that is why these sort of programs are very, very important. As like Satya sir said, it's important to understand the kind of range of machines that you have at your disposal today, making a calculated decision, not overspending. And I think it's a fantastic concept, and I'm looking forward to learn myself.
Thank you so much, sir. It's very gracious of you to say that you are going to learn. We always look forward to learning from seniors like you, and we have learned a lot. And actually, speaking, the topic was very relevant when Remedio wanted to do a webinar with us, which is the sponsor of this webinar also. So they wanted us to target the younger ophthalmologists to start retina practice. And then we thought that actually this is a very common problem, and most of the retina fellows who come out, they due to fear of lot of investment, as told by both of you, they tend to join some hospital and never dare to. Many, most of them never dare to start their own practice. There are few standouts, those who are in panel and chairpersons who have done so. But that's the message that we want to give through this webinar. And I think Dr. Pratik Kakkar is one of the apt speakers for this. He is going to tell about his journey, how he started his solo retina practice in the smart way, the smart planning of the retina clinic. Over to you, Dr. Pratik.
So, thank you, Team YOSI, Sunandini, Naresh, and all of the panelists for welcoming me. It's a great honor to actually speak on such a topic, and it's actually close to my heart because I am one of the few people who are in my region, at least I know, who started this, and I've motivated other of my friends to actually do the same and start their own retina practice. I'm just going to share my own experience a little and guide my juniors, whomsoever needed later. So, is my screen visible?
Yes.
The presentation. Thank you. So, then what is the need for a person to start their own retina practice is actually twofold or multifold rather. It's not just the earnings that you will get out of it. More than that, it is the satisfaction that you get once you started your own practice. You're not being dictated by the corporates who are exploiting you for unnecessary reasons, who are asking you to do surgery which you don't want to do. So for that, and you also need to understand that nowadays the patients actually want to go to a specialist. They don't want to go to a general ophthalmologist who can cater to every of their needs. They want that they should be treated by a specialist, and that's changing not just in the urban areas but in the semi-urban or in the rural areas as well. And since our country is having a lot of diabetic patients and other complicated issues, we need more retina specialists to go ahead. So when to start? Like Dr. Piyush said, that it's very important that you should have enough training. You should have enough confidence in yourself that you are trained enough and you can manage patients well. And for that, you need to have a decent amount of training. Once you've done that, you need to gain enough surgical experience as well. Many of the fellowships might not give you a good hands-on. So my recommendation to most of my juniors would be that you should go ahead, maybe join a charitable institute or another government institute, do a residency for a while, 6 months, 12 months to gain enough surgical experience as well, because that is what is going to come in handy when you practice it tomorrow. Apart from that, once you're done with the charitable or the government or the teaching institutes, you need to go ahead and actually observe how the private practice works. It's pretty different from how what we do in the government setups, where we are dictating the terms, while in the private practice we need to keep the patient on board with our decisions. Even for an eye drop, the patient will actually question you twice, which is at times initial days it kind of hurts you. Once this all is done, you have to take a leap of faith and go ahead. You need a financial support, maybe your parents, maybe your own money that you've accumulated over a period of time, and have some patience. So first and foremost is the location picking. You need to have your liability is low. If you have any space which is pre-owned, that is probably the best to start with. One of the few senior ophthalmologists have told me that they started their practice from a garage, their own homes, their outward areas where they could just start, take a table and start their own practice. This might not actually be true for retina people because we need a little larger space. We need to accumulate more equipment. But yes, you need a place to start. If you have to pick a place, maybe pick a place where the competition of other retina specialists is low and you have a decent amount of referral potential, being important that you have other physicians or ophthalmologists around you. And especially you should have a space to expand later. Once you're sure that yes, this is working out, you can actually start. Another way to go about it is that you can actually join another clinic or a hospital where you can start a retina wing which is not already existing there. The advantage of that would be that you are already having a place where there is footfall. You have another ophthalmologist who is actually directly referring you the patient, and it becomes easy for you to actually start investing, and he may also cooperate with that. You might lose a little general practice, such as the refractive or the cataract patients, but then again, your scope or the logarithmic, ascent would be faster. The most important aspect, like Dr. Tiwari was mentioning, is the finances. Actually, that is very tricky, and I would say that amount of 30 lakhs would be a decent amount to start off as a corpus, because it is the basic equipment that you need for retina practice. So you can do that either via personal capital. These days, loans are pretty easy, either professional loan, or actually certain companies would provide you bundling with certain equipments. So that is something that can be thought about, but it's always better to do that on your own. Okay, so that you do not later on worry about the loans and its interests. So certain expenses might be just one time, such as property if you are buying one, or a recurring if you are actually renting, and main would be the equipment. Certain recurring expenses such as staff, consumables, and the other things you need to plan out for about 1 year, at least 6 months to 1 year, so that you can actually manage. So keep them low as much as possible. Don't invest heavily there. So the essential equipment that I have uh, bulleted down here as the slit lamp, an indirect with requisite lenses, a fundus camera, and yes, an OCT is actually very necessary, because that is one thing that I had from day one in my practice, and that has worked out really well for me. It might seem expensive in the beginning, but yes, that is something which is actually guiding for most of our cases when we have to select like what to do and what not to do. And a fundus camera would actually help us. A Remedio provides a very good, decent, cheap kind of a fundus camera, which will help most of you to actually channelize and guide your patients to what is wrong with their eye. Once they see their eye photographs, it convinces them more to actually go for the treatment and understand what's actually going around with their eye. And yes, a retinal laser, especially if you are into ROP practice, it is very important. Rest of the things I've kept as optional, which might be debatable, especially an angiography machine. I invested later on it because I know it is not going to give me enough ROI. And now, slowly, as I'm building my practice, I have actually acquired all of these equipments. So once I have done my surgical setup, now I have a bit of equipment as well. So this is just a basic chart so that everyone can go through this. So basic equipment, if you just calculate it out, an average pricing would be somewhere around 30 lakhs, which would help you to actually just propel your retina practice in the beginning days. Later on, you can add equipments based on what expenses you want. Again, these expenses are very variable. I've just put down the basic ones here. So herein, I would recommend everybody that you should plan your retina setup in such a way that you can actually complete your medical retina practice by giving intravitreal injections. I would strongly suggest that you should have enough space for at least a small OT, preferably a modular one if you can manage that, or apart from that, at least a room where you can just do a basic sterile procedure of intravitreal injection. That way, you can at least start with a medical retina practice, and it would actually be worthwhile for the referring doctors also for you to actually go ahead. Once you've done that, then yes, maybe transform it into a proper surgical practice where you will have to invest at least say 20 lakhs or so in your machinery and about similar amount in your microscope upgrades. So, and a basic setup for any kind of an ophthalmologist would be something like this, which will be somewhere around 5 to 10 lakhs. If you want a smarter clinic, you will have an EMR software, IT setups where you will have enough computers and Wi-Fi enabled setups where you can just send the patients their records, which is pretty common also these days. Next important aspect would be a team planning, because it's not always easy. Once you start a private practice, you get everything in your training sessions, but here you need an optometrist who's actually well trained to manage your OCTs. Once you have enough patient load, I normally at least advise my optometrist to go ahead and do an OCT, and they help me with that. Same goes for a technician. He should be at least having a basic idea about assisting VR cases. You can train them up later. And a very important aspect would be a public relation manager or a public relation officer. That is very important for building your network base for referral patients. Initially, I did that on my own. I used to visit other practitioners, other ophthalmologists, discussing with them, or at least have a talk off and on, so that they understand that there is somebody sitting here who can actually help them out once they are in trouble. And you need to regularly train your staff members so that they know what is happening around. Once many a times it's not the you that the patient might just actually talk to. It's your staff that they talk to, and that is when they actually decide to go ahead with a particular procedure, a test, or a surgery. It is very important that you train your staff as well, so they should know what's going around. Branding and marketing probably has been covered a lot previously, but goes without saying, it is important. One important aspect that I only want to highlight is you should have referral meetups with your doctors who are referring you patients. At least keep in touch with them, maybe via CMA presentations, so that they know what's going around, what's happening, what is the latest, so that they are also up to date. And apart from that, for any practice to grow, you need to do certain free checkup camps. Maybe for an example, you can do a discounted OPD day, diabetic retinopathy screening. So, say for example, on Wednesday or Thursdays, you can go ahead and give patients allowance to do a free eye-related exams. So that way, you can actually get more footfalls. Patients see you, that they know that there is somebody around here. I needed to do this for initial 4-5 years of my practice. Till then, I used to still hear from people around me that we didn't know that you're sitting in our locality, that there is another doctor sitting in our locality. So it's like that. People don't tend to recall so easily. You need to keep on regularly doing that. So legal and regulatory requirements are actually common for all kind of practices. It's nothing special for retina practice, I'd say. So one thing I would like to touch upon is you should avoid certain mistakes. Just like Dr. Satya was saying, you should not invest heavily on the technology initially. That is because I strongly believe your liabilities should be low so that you're not forced to do things that you don't want to do. You should always look for ROIs and imagine that your machine is not going to work beyond 10 years. So plan it in such a way that it's going to give you enough ROI. So for example, for myself, I actually started off planning that my OCT would work for 10 years. So I wanted it from the day one. For my angiography, I started it only for a couple of years back because I know it's not going to give me, I do not have enough patients to actually cater it to, but its life is going to die down if I have not been using it for the initial few years. It all could be variable. One important aspect, do not neglect your patient experiences because patients will say certain things which you will realize later. And that is going to make a lot of difference in why the patient will choose you over the other practitioner. Do not take on challenging cases initially. You will just burn your fingers. Do not be a hero when you are just right into your practice. Wait for your own name to grow. Once you've done that, you will automatically get patients where you can actually do your thing. Okay. And make sure that you are keeping your referring surgeons in touch with the cases, what's the progress, because many a times the referring surgeons will refer you back once they know that you are handling their cases nicely, and that is something that will make some difference. And tips, like I said, financial planning is very, very important. Pick a good location, good access, so that the patients can come. Most of our patients are usually old patients who need a good access. So I would rather say pick a location which is on the ground floor probably, so that they can actually come into you, something like that. Okay. Be honest in your opinions. Don't expect the patients. I would say that most of the time, 50% or rather than less than that, patients would be actually converting to surgeries or any kind of procedures. Don't be in a hurry. Just wait it out. Give it time. Patients will actually realize your potential and they will probably come back to you. Help out your fellow doctors who are fellow ophthalmologists, such as who are having some complications. They will come back to you. They will going to bring some patients back to you. And just be consistent with what you do. Just wait it out. Things will work out. It's going to be a slow process. It's a slow burn. So don't worry about failing. It's going to come around. That's what I'd like to just summarize with. Thank you, everyone.
Thank you so much, Dr. Pratik. I think that was a very wonderful and very concise, but all the relevant points that were required has been there. We'll initiate the discussion, and before we move on to panelists, we'll take Dr. BP Kashyap's comment. He is a senior consultant heading a big practice at Ranchi, and Sir has taken. Sir is, I think, Sir was second generation when he took over, and he has taken the practice to another level. He's the leading surgeon from Jharkhand. So, Sir is not well, so we will take his comment before he leaves, and then we'll initiate the discussion. Please.
Thank you, Nilesh. Thank you very much for giving me the opportunity, especially to make my younger generation, younger colleagues understand that when I started the retinal surgery, I was people used to refer me the cases for indirect ophthalmoscopy. And when I drew the diagram, very nice diagram, they used to take it, and then with that diagram, they used to refer the patient to, 3-tier, you understand where. They used to refer the cases there. But suddenly somebody was doing a pterygium surgery and he gave injection in such a way that the patient developed retinal detachment. So I did this surgery. The patient got 6/6 vision. Even then, I did not get the referrals from them. It was a very, very difficult situation those days. People didn't know how to see the retina properly. And, we were also primitive. I used to hold my 20 diopter lens in one of my hand and the three functional vitrectomy mini phage in the other hand used to do vitrectomy. Well, the belt buckle has not changed much, but then vitrectomy has changed a lot, and it's good and it's become easier, much easier. I said in our time it was so easy, it was so difficult to do, but then the things have, and the changes in the instrumentation, they have changed the surgery so easy. My other point to tell you is what I believe is whenever you start with a bang. Start with the bang. Everybody's doing retina surgery, VR surgery. At one time, I was one person in whole Bihar and Jharkhand. Now there are 13 people in Ranchi. If you have to start a retina picture surgery, you have to start a bang. You have to have the best possible machines. When I bought the first microscope, it was, loaded with the camera and all that, and I won the first video prize in, ASUC and all that. So my thing is, what I say is, you start with a bang. No hacky maggy. Yeah, abhi, you take this and then you upgrade that, then upgrade that. You'll be in trouble. You are in distress. You'll be thinking how to, dispose of the previous ones. So start with a bang. Number 3, you must get the referrals. You must get the referrals. For that, you have to keep on talking. You have to keep in touch with the people. You have to go to the conference. You have to meet Piyush Bansal. You have to meet Nilesh. You have to meet Pranav Saluja. You have to meet everybody. And must have a, social gathering also. When you are, you let yourself free and then talk. And then, that is also very important. So my idea of intervening in between was, how I started and what I feel now, because my younger generation, my son has also started. Nobody wanted to see him because dad is here. Beta ko kyun dikhayega? But then, he met people and then he showed his surgery. So he had to purchase a lot of good equipments. सत्या जी किसी को बोल रहे हैं आप? Probably he was talking to somebody else. So what I'm saying is, you must have a good machine. You must show the result. Keep the videos, show it, attend all the conferences, and and then make friends. And the social part is also very important, especially Piyush Bansal. I know him because he's from my same college, and we meet quite often. So we are so together. Even Nilesh ji se मैं हमेशा मिलते रहता हूँ, and सत्य जी से हमेशा मिलते रहता हूँ. So meeting people is also very, very important. And at the last, यहाँ जो है वो तो is there. अगर है भाग्य में तो मिलेगा. But we should try our level best. Thank you for giving me the opportunity to मैं कुछ शब्द कर सकूं. I'm not well, so I'll take rest. I'll take leave.
Thank you so much, sir. Thank you so much. And you have touched upon a very important topic actually, and probably will come you to become a chairperson for that session, probably 3, 4 webinars down the line. Actually, this is a trick, an art, how to hand over your practice to second generation, and second generation how to take over that practice. So probably down the line, 3, 4 webinars, we will have you and Vibhuti sir both as speaker and panel chairperson for that session. So thank you, sir. Thank you for joining.
Thank you, Liz. Thank you very much. Piyush, milte hain. Okay, bye.
Before BP sir
Hi,
leave,
everybody. I'll take leave. I'm not well. I'll take leave. Thank you so much.
Yeah.
So, sir, as BP sir was telling, sir has told that we have to start with a bang, get all the best machines. But we'll take the comments from the young panelists who are there, how they have started their practice, starting with Dr. Pranod and Dr. Kshitij. How do you feel? Do you want to build brick by brick, or you want to like build a mansion first and then let everybody in?
I think it depends mostly whether you have the money in the start, because I think first step for me at right now is prioritizing the essential diagnostics and covering the broad spectrum of the retinal diseases, like a good quality OCT and B scan. I would just say that, like Kashyap sir has commented, that it is better to buy a very good machine rather than going for a weaker one and then replacing it later on. So, if you are able to buy a good quality OCT machine at the first step and a B scan and a good microscope, I think especially vitrectomy machines and the microscope should be the best, because it is the surgical results that will go out, and that is what will make your name. So, I think investing in these is more important rather than going for an Octa or a FFA during the start. Especially for me, it is going really good with this. So I'm building it step by step. And rather than going for Octa, I don't have an Octa, I outsource it. I've talked to another retina surgeon who has a Octa. I get the Octa done and then he refers me back. And similar is for the FFA also. I think basically I have a good quality OCT machine and I've bought a B scan right now because that is very important for retina practice, especially the medical part. And then I'm prioritizing getting a very good microscope and a vitrectomy machine. And especially the machine that you've learned in on is more important. Like I've learned on Constellation, so I would prefer buying a Constellation at the start, uh, because I think I would be able to give better results and I would be more confident in doing all the surgeries in that. Like even the complicated surgeries, I would be easily able to take that. But I think that depends on person to person and what they can do exactly. So you have to see the return of investment also, the amount of footfall you're getting for your patients, and accordingly, invest. Uh, I think that is it.
Thank you,
Two
Dr.
very
Kshitij.
yeah,
When
two
just I'll ask you the one question on follow-up. When do you feel that the OPD setup is enough and you go on and start adding things to your OT?
I think I'm waiting for a better footfall right now. If I will get more retina patients and more footfall, like if I'm operating, like Dr. Pradeep sir had already said that when he started, he was thinking of getting 2 to 4 surgeries, and that was also enough for a retina practice to start. So right now I'm getting around 10 to 14 patients. So I'm now starting to, thinking of investing more in the setup because I'm getting more investment out of it, and I'm thinking that I can expand, I can build on it.
Thank you, Dr. Kshitij. Your take.
ophthalmology is one branch where investment will never cease to exist. We are spoiled for choices, and uh, the range of equipments, it ranges from a few lakhs to several crores. So it all depends, it all boils down to what is the need and what patient data you are actually catering to. And basically you should be able to provide good patient satisfaction and good surgical outcomes. So the choice of equipments and machinery should be such that it gives you a good ROI as well as a good patient satisfaction. And two very important points that Dr. Kashyap sir highlighted was that you start with a bang and your presence must be felt. People all around you must be knowing that you with such and such qualifications and with such and such skill set of working in this particular town or in this particular locality. And one very effective way is advertising through the conventional media, the newspaper, through radios. And the other very important point that Dr. Kashyap sir highlighted was uh, the social role of your practice. We as retina surgeons, we must be viewing our general ophthalmologists working around us as friends and not as competitors, because they are the ones in the early days of our career who give most of the referrals. So it is of utmost importance that we maintain highly cordial relations with them, because they are the ones who are going to be providing us with the major patient input in the early days of the career.
Okay, and how do you envision, like, you're talking about making friends with general ophthalmologists? When will you bring them into your own practice and expand your retina setup? Like, when do you think adding either general ophthalmologists to your center or in satellite centers that will feed you
When
your
you
main center?
when you start feeling the heat that the patient footfall is going beyond your physical capacity, management of patients is becoming chaotic in the waiting hall. So then it's the time when you need to amp up the team members, and that all depends that are you having more number of retina patients which you are finding difficult to cater to, or is it the general ophthalmology patients which you are finding difficult to cater to? So if it is, you're basically turning around new retina patients, so adding a associate would be more meaningful. But that also comes with a caveat, because that associate would also be your competitor. So it's a slightly slippery situation which has no universal answer, and it all depends in what circumstances you are working in. So once you start feeling that things are slipping beyond your control and the amount of patient influx that you are getting is more than what you can actually manage, so that then is the time, I believe, to increase the number of doctors in your team.
Thank you so much. And let's bring in Dr. Anant also for his comments. Anant sir, I have two questions for you. One is, when do you feel that the retina staff, the OT staff in retina has to be trained, especially for the retina practice, or does the general ophthalmology OT staff help you in that? And second question will be, what do you feel about the government schemes that are there to bring in more patients into your retina practice?
This question is actually first question about training. There's a lot of instruments involved, and a lot of multiple instruments and machine related small parts. There is a small tubing, aspiration tubing, which is left alone and not autoclaved or heated properly. You may not be able to go ahead with the case. So, what I would recommend is a checklist of the equipment. Make sure that the staff does the runs through a checklist and makes your theater ready for the checklist. Regarding something like a scleral depression and all these things have to be taught to staff patiently, um, and with time they learn it. So if you have a cataract trained staff, it will not be that difficult to train them to VR, given the point that you spend some time with them. Coming to the second question about the feasibility of schemes and all. So there are few procedures which have rates at par with the, but there are few procedures which are not. So I think you have a mixed bag of procedures. I think you can match the financial part of it, and we make sure that the payment from the government institutes is in time. Say you keep doing free services and not getting paid in time. Say it takes 6 or 8 months. It not may not be economical viable. So getting paid in time, I think, is one thing, and taking schemes definitely is a good idea to serve all sections of the society.
Thank you so much, sir. Sundari ma'am, your questions, please.
Yeah, so my questions will be for the chairperson. Sir, though, one thing that I wanted to ask, that everybody now talks about, owning a Centurion machine. And what I have seen that people who are from retina background, they have different Alcon machines for, doing the VR. And so do you think investing on two different machines is better, or we should have one high-end machine like Centurion? How should you, tell this to the youngsters? How should they plan? Satyaprakash sir.
Sir, mute.
So you are on mute, sir.
If you want to invest on a single machine and do most of the thing, I would suggest go for a Constellation. This machine is having a beautiful cataract system also, and it is as good as Centurion. There is just minimal difference of that IOP maintenance. That's all. Otherwise, it is Ozil handpiece and everything is there. So for initial period of my practice, for 2 to 3 years, I just worked on constellation and cataract. Also used to be done by that same machine. My anterior segment colleagues also used to do cataract with that machine. So one single machine doing both vitreoretina and cataract. That is the best machine. The same thing is available in other companies also, like Faros from Otley. That machine also is a very good cataract machine, as well as that machine is having a decent vitrectomy system. So spending on a single machine and doing both cataract as well as vitreoretina is best for like machine investment. And go for a single microscope like this Topcon OMS 800 or some starting microscope of Carl Zeiss like Lumira 300, which is having equipped with XY, as well as so that you can attach either a biome or viewing system, or if you are comfortable with doing surgery with contact lenses, that would further save the money for you. Like biomes nowadays have become very costly, almost equal to a microscope, while that contact lens is just 1.5 to 2 lakhs, and that also works very well. So single machine, single microscope, and in OPD you should start with one good OCT machine with basic fundus functioning. Majority of the OCT machine gives fundus functioning. So you can start with that. You can do OCT, majority of your diagnosis are clear with that. You can take central fundus photo also. You can explain to the patient. And with that, you can start. And once you reach that, okay, you have a good phaco or vitrectomy machine, a microscope, and OCT, and if you are meeting up the expenses of those machine like EMI, monthly EMI expense and all, once you have achieved break even for those machines, then you can think of adding more machines. Like you can go for a fundus camera, and then you can add angiography. Then the rest things can come later on. But to start with a single machine which can do vitrectomy as well as phaco is my suggestion to go for any retina colleague who is starting or thinking of starting a practice independently.
Thank you so much, sir. Piyush, sir, what is your take on having two different machines or single machines? Because you have multiple centers, you're visiting also multiple these centers, you have your own centers also. So how do you manage in different centers?
I would disagree with SPT. I mean, of course, his way of looking at things is very correct. There's no wrong or correct way over here. It's just a matter of your perspective. Now, if you ask about single machine or multiple machine, first of all, you have to see whether you're going to be doing cataracts. It's you're primarily a retina surgeon, or whether you are, it's a mixed kind bag kind of a practice, whether you or other surgeons are going to be operating. Now, I personally would not be comfortable if there are other people who are operating on the same machine for cataracts, because if there is a breakdown, my vitrectomy is going to suffer. Especially having a high-end machine like Constellation, where I'm already expending a lot on the cassettes, I'm all with the packs that they have. If anything goes wrong, my work comes to a standstill. So from day one of my practice, I've had separate machine for, say, for phaco, and special separate machine for vitrectomy. Now, of course, bigger hospitals choose to take combined machines, but many of them also have a backup machine as well. So unless you are prepared to do something like that, I would not recommend that. Secondly, my impression would be that spend more on the microscope rather than the vitrectomy initially. In fact, if you need to buy a vitrectomy a little later, couple of months later, that would be a better option, because your microscope is going to be there for a longer time. Your visualization needs to be as good as possible. Machines with more moving parts are preferred to be bought new rather than used machines, which is a very common fad these days of buying refurbished instruments, but then sitting with the machine that is defunct or not working, and then spending a lot on getting it rectified. So getting a microscope is more important for me. Having a fantastic operational theater setup is more important. It's okay if I buy a machine after some time, acquire instruments stepwise, as Prateek mentioned, as Dr. Prateek mentioned, acquire them stepwise. I made this mistake of buying an angiography and FFA as the first machine I literally ordered. Of course, a new retina surgeon in those days, but I had immense amount of satisfaction. See, I never looked at it with the point of view of ROI. And even right now, if you are, say, for example, earning a certain amount of money, you broken even, like SPT said, all the EMIs are done, and then you can upgrade to a new machine. I would say, I would differ there. It's rather time that you focus on investing your money also, not just get pumping everything back into ophthalmology. Of course, ophthalmology is important, but technology is going to keep changing. You will have to keep upgrading your skills, whether it's related to machines or anything else. So again, you have to keep a balance. Just like your personal and your work life, you have to keep a balance between how much you're spending, how much you're getting back, what is giving you satisfaction. Like Kshitij mentioned, that what strata of patients you're examining. We have excellent Indian made machines now. I don't know, almost everybody has heard of Reticare. There are some excellent made in India machines, Remedio, for example. So visualization is important. Spend good on the visualization. Have explore the option of other machines also, just not what you have learned in your fellowship or in your in the other hospitals that you worked. Explore other machines, take demos. You never know what is going to work good in your hands. And what is important is wherever you can save, save. But don't compromise on the things that you feel that are going to give you suboptimal results.
Right.
If
I
any,
think for younger people, the most important thing is the finances, obviously. But I think if somebody can figure out the finances, they can definitely have two different machines, for if they want to expand, definitely. But initially, maybe I'm not a retina surgeon. I cannot comment on this. But maybe even a single machine in the start, it is okay, and then they can. But then obviously, Dr. Kashyap sir said, start with a bang, have everything together from the day one, and you start together at a bang.
then it all
So
that is
definitely,
very true, Surandhi. But again, what happens is you just like Pranav said, it all boils down to how much of money you have laying around with you. See, BP sir has a hospital the size of Pune. Okay,
oh,
what I mean to say is that his father was already such a big established name. BP sir took it to another level, and now Bibhuti, I'm sure, is going to take it to another level. But not everybody is as privileged.
right, sir. Right,
So
sir.
we don't you don't try to fit somebody else's shoe. Sometimes we need to start from scratch, and when we do that, you have to start take small steps at a time. Because if you have a fall, many people are not able to take the kind of injuries that come with it. So
Yes.
going out with a big bang is very good if you can sustain the losses.
Dr.
Fine,
Sunandi,
sir.
we did
Yes,
something,
sir.
a mix of what both of them said. So we had a constellation and we did, I have my counterpart who does cataracts. I don't do cataracts now. So we had a single constellation. We did cataracts and retina with that. And when within 3 to 4 months we were confident that, we are doing good and we might be able to pull it off. So then we bought an Oatly machine again. So now
Okay.
we have 4, 5 phaco machines, 2 VR machines. So slowly it's building up, slowly makes more sense when you're starting off new.
Right, sir. So, with this, we move to our next speaker, Dr. Devakan Mishra, sir, who is going to speak about wide field retinal imaging from traditional to the newer technologies.
Okay, I was on mute myself. Just a minute here. Just a second, Dr. Sunandi. I'm having some issues here. You can continue the discussion. I'll just get my slides ready.
So, in the meantime, I can just take one final question so that we are not behind time. So, this is for Pranav, Dr. Pranav, that what strategies help build a consistent referral base from general ophthalmologist and optometrist for you?
Right. Thank you. So, I think first of all, the problem with me is that I do cataracts and retina both. So it is more difficult to build the trust with the general ophthalmologist. So I usually refer back their patient whenever they send me a retina patient, first of all, to manage their retinal issue. And even if they are sending me a retinal detachment surgery or a diabetic vitrectomy surgery, which has a cataract, I always send the patient back for them to operate, and then ask the patient to come back to me. And even after operating, I always send the patient back once to them so that they can see how I've operated and whether they are, happy with the results. And I think that builds a lot of trust with the general ophthalmologist. Optometrist is a different game altogether. I think giving CMEs, involving them in a lot of patient education is more important. These days, people are going for a cut-based system, which we don't practice usually. But I think if you just give them a little bit of respect, also at that point, also they, prefer referring, because most of these optometrists, especially in Uttar Pradesh, these are the ones who are practicing in the periphery, and they have the major chunk of the patients in the periphery, and these are the ones who can refer you to being a specialist. And the problem with the optometrist is that they usually do not refer you if they are in the same city. They tend to refer the patients outside, so the patient remains there as only. But if you build some trust and ask the patient to go back to them also, that also makes your practice better. And for the ophthalmologist, I prefer going to each of them and meeting them in CME especially, and thanking them if they've referred me a patient. And right now also, like during the start, it is better to keep on calling these seniors and all of the general ophthalmologists, uh, and I think that helps a lot.
Thank you so much, Dr. Pranav. I think sir should be ready with his presentation now. Devakant sir. Yes.
Can you see my slides? Yeah, perfect.
Yes,
So
we can.
yeah, this talk is on behalf of Remedio, the sponsors for us today. So we'll be talking about how retinal imaging has evolved, and this will be more from Remedio's perspective. Traditionally, all of us during our residency, my residency was all about a direct ophthalmoscope, which seems like a very primitive equipment now, with around 10 to 15 degree of view, and highly magnified view. Then we moved on to indirect ophthalmoscope during my DNB and my fellowship. So that still happens to be my go-to equipment while I see my retina patients. But other things like our traditional fundus cameras, which give us around 30 to 45 degree of view, and now we have the wide field, which is around 55 to 100 degree field of view, and the ultra wide field imaging, which gives us a whooping 110 to almost 200 degree view. So now, what has happened is that Remedio has come with the FOP NM10, which is a small handheld retinal camera, which I have employed in my vision centers. All my vision centers are equipped with these things. So these are very portable, lightweight, handheld equipments, and very easy to use. And these are non-mediatric also. They have an AI platforms that are embedded in it, which give you, without even net connectivity, they give you some reading. So this helps, some of our general ophthalmologists, and in our case, gives some clues to our, optometrists who are handling it. So these are, FDA listed and approved by CE and HSA. So this is the Medios HI AI that they follow. So they have an offline system which does screening for AI-based screening for diabetic retinopathy, glaucoma, and AMD as well. It's quite quick and very efficient. And we have tried to validate it ourselves in our practice, and till now it looks very efficient to us. So the advantages of these traditional imaging system is, of course, it's a very limited field of view. As we discussed, only 30 to 45 degrees, and obviously you miss most of the peripheral retinal pathologies. The screening usually you can do for ARMD, diabetic retinopathy, but rest of the other pathologies do get missed out. A lot of patient cooperation is needed, and the screening and all these things, the time increases for you, and you don't get that benefit that you're looking for. So wide field imaging is, if a wide field fundus camera does a single shot image, which is around 55 to 100 degree, which is broader than the conventional one. And in this, the Remedio Pristine 5.0 system, they do it with four images and covers around 116 degree of the retina. And so, of course, it gives us a larger field of view and you can detect more pathologies. And it's relatively easier than our traditional fundus cameras. So again, coming back to the differences of traditional imaging, which is restricted to around 30 to 45, and with wide field imaging, we get a larger field of view of around 55 to 100. So the basic difference comes while examining the peripheral retina. So, what the studies have shown that these wild field imaging helps us in detecting more than around 30% of more peripheral abnormalities compared to the standard fundus imaging. As in this image, a traditional fundus camera has missed the small pathology, which our Remedio camera has picked up. So these are some other images of peripheral pathologies that this picks up. And now we also know and understand that, in diabetic retinopathy also there is a lot of role of examining the peripheral retina when you're looking at, ischemia in the periphery and looking at CNP areas, of course, and neovascularization also. So this is quite useful, and when incorporated with an angiogram becomes really important. So the ultra wide field system by Remedio is known as Pristine 1.5. And again, I think all of us know about how important ultra wide field imaging is in diabetic retinopathy and even in conditions like retinal vein occlusion, apart from the peripheral degenerations. So these are certain comparisons with the other existing systems that they have given us, and I feel it fairly does well in comparison to most of these standard traditional ultra wide field imaging systems. So again, why it is important, and just to conclude it, it becomes very useful in a busy OPD, and I think Nilesh can touch more upon this later because he does a lot of wide field imaging for most of his patients. And I don't own a wide field or an ultra wide field imaging system yet, and I'm hoping to discuss with you guys how, what importance it could be. What I feel, the disease detection part, I can do that myself quite efficiently. I have trained my anterior segment surgeons to look for these pathologies. So, but one thing I do agree that it will definitely save time and, remove the chances of human error. And if you have such a system, it works. You can share images. And I've seen my colleagues who have an ultra wide field imaging system. They share their anterior segment surgeons or colleagues, or their optometrists send them images, and they can take decisions while they are not in the clinic as well. So these are few points on these ultra wide field and wide field imaging systems. Thank you.
Thank you so much, sir. Sir, so this is a non-pediatric device, the Remedio one.
Yes, these are non-pediatric ones, but of course better with when you dilate them.
The image quality becomes more
Yes,
better.
less
But I
artifact.
think but I think Remedio is one of the first companies which had actually started with this mobile devices, and I think a lot of I think initially it was from Arvind or Shankar, I don't know, remember exactly, but they have all this from the vision centers, or Aditya Jyot also had something like this similar kind of thing that you were saying, sir. That from the vision centers they were sending it to the main center, and they were able to detect the diabetic retinopathy or something. I think they also published the one of the largest study also the same, if
It
I'm
was
not
from
wrong.
Arvind. It was in collaboration with Google. So Google diabetic
Hmm.
retinopathy study it was, and
Hmm.
it was done in a similar fashion when peripheral centers actually were screened with this these handheld devices. And what Remedio has done, which was not done beforehand, the devices are available with Bosch and many other company also. But Remedio has utilized the power of the smartphone camera. So the resolution is much more. If you go for a single chip medical grade camera that Bosch uses, the resolution sometimes is very poor. With this, the auto brightness and everything that is maximized on the smartphone camera, that gives the advantage that is there. But now, this is one question that always comes, because these cameras are come very cheap when it compared to the traditional fundus camera that are coming from a house of, say, Zeiss, Topcon, or Canon, similar. We'll take opinion of both chairpersons. When somebody is starting with the retina practice, because fundus cameras are not revenue generating per se, so, do you feel they should go for a camera where they have additional imaging capabilities such as FFA, ICG, autofluorescence, the traditional ones, or just invest into a simple handheld devices like this? When you are starting in a retina practice, not considering they are in periphery vision center or somebody else is uh, doing that.
When you are starting, it is better to go with these low cost devices because it actually addresses the purpose. There is no bigger advantage in initial phase by getting such costly instruments from Zeiss or Nidec or for that matter this Canon cameras. Remedio very well serves. What are the quoting prices of their ultra wide field fundus camera? This Remedio.
So we have not taken it, but I
Cognizance. You haven't taken, but that would be a great thing for any person who is planning to start the practice, because anyway you have to just document the finding. Many a times to convince the patient to counsel them properly, if there is something like, if there is a old branch vein occlusion, there is no macular edema, but there is a large NV and ischemic area, and that the patient needs laser sector laser PRP. So it is very good to take a fundus picture and show them that, see, although you are seeing perfectly, you have a serious lesion lurking in the eye. It can bleed anytime and may lead to loss of vision. So, like that, it solves more than a diagnostic device. Is actually serves a purpose of doing counseling to the patient. Patients are really get convinced after seeing the image of their disturbed retina, distorted retina, detached retina, or bleeding or whatever. So they must go in initial phase with these remedial like devices. And once you have a decent practice, you can manage to pay the EMI of bigger instruments. You should go for ultra wide field fundus fluorescein imaging devices also. That is required actually for a core retina surgeon. But slowly you can, like, my fundus camera journey started with Carl Zeiss older model fundus camera of 20-25 lakhs, and then later on I thought of acquiring wide field and I went for Mirante. Now with some time, due to pseudo color projections and all, I was not happy with that picture. So recently I bought Claris 700 as well. So the journey continues. You can add, but still Claris 700 takes very good picture, but peripheral pictures are more easily taken by Mirante. So I'm using both and I'm finding it very good to convince my patients of a small HST, retinal holes, lattices who needs intervention without any symptoms. So such patients are very easy to convince for procedure if you have an ultra wide field fundus scan.
Nilesh,
Thank you, sir. You, sir. Yes,
let
sir.
me break it down. Your question was, is there any value add to, or rather, is it pertinent to have value add onto your fundus camera? See, again, it boils down to purpose. What is your purpose? Like Dr. Divakan said, he's using many of these Remedio handhelds and the vision centers. Is he using them at his main center? So again, you have to decide what you want for the device first. Remedio handhelds are doing excellent work in terms of, say, screening vision-threatening diabetic retinopathies. So those patients can be picked up slightly earlier. But is it going to be a very good tool for documentation? The handheld I'm talking about. See, the Remedio and many other companies are giving us excellent, comparatively, I'm not saying low-cost devices, I'm saying comparatively low-cost devices. So, excuse me. So what is important is you know what the purpose is. If your purpose is documentation, you're in an institute, or if you're in a private practice, you want to present your work, are those pictures going to be worthy of presentation? Are those pictures going to be worthy of counseling to a particular patient? Are your patients going to be illiterate patients who just need to see an image, or are those patients going to be top-notch professionals who are going to go back and do a background search, and who are going to use AI today and see whether what you're speaking makes sense? So this is with regards to the fundus camera. If you can, definitely go for a bigger, better machine. SPT sir also mentioned he started off with the Carl Zeiss. So Carl Zeiss is by no means a straightforward machine. Having a machine 25 years back, which costed 25 lakhs, is not something that everybody can do. But then he got into it the right way. Rather than going into buying something cheaper, he bought something that is good. It is
No,
good.
at that time, I think that was the cheapest decent camera, I can say. Remedio was not available. And I think one more Indian company, Forus was available, but I was really not impressed with the quality of the Forus fundus camera. So I went with Carl Zeiss, that
Exactly.
simple some camera. But yes, that was a decent one. It used to do angiography. It used to do take picture. Even that was enabled ICG also, although I did a very few ICG with that machine, but that was not that costly. But nowadays, the younger generation is really fortunate that even uh, cheaper fundus camera are available, and they are really good in quality. They take decent pictures.
But I think what happens is inflation affects everything. It's the salaries also that have increased as compared to 10 years ago. It's the amount of money that we are charging to patients is also increased as compared to 10 years ago. So I don't think it's such a big difference, honestly speaking. I started off with a Zeiss as well, and I still have it, and it gives me fantastic images. The angiography is fantastic in it. Of course, I do not want to get into an ICG. The reason is because I realize that PDT is going to become a difficult proposition that I can offer to patients in the next 4 to 5 years. So that is the reason that I did not go for an ICG. But coming back to the question, should you add onto your fundus camera? Of course, if you have the moolah for it, if you have the money to throw in, then you should definitely. Everything adds value, whether it's a fundus autofluorescence, whether it is angiography. Right from the start, I knew that I'm going to have a lot of patients purely retina. See, I was very clear that I want to do retina. I'm not going to do retina for 1 or 2 years or 4 or 5 years and then I'm going to jump into cataract. I'm going to continue retina and gradually move on from everything else only purely to retina. So when I have patients with CSCR coming to me, I need to find where the leak is if I'm going to laser there. So I need an angiography. Whether those patients are going to be less or more in number was the only question. So again, that became an value add, having an angiography. If you have an ICG like he did, then you could pick up more cases of PCD. At least you would know what you're dealing with. You can counsel your patients better. But now with the added advantage of having comparatively lower cost machines available, if the quality is good, then why not? You should explore them. But if you can add value to your machines, you should. But you should also keep in mind that it's not going to directly supplement your income. Like say, for example, no CT would. An Octa is too premature in today's day to give you any valuable information as compared to an angiography, a conventional angiography. I would get more information out of a conventional angiography as compared to an Octa. Yes, if I am academically inclined, if I have the money, I would want to get an Octa. I hope I've answered the question, or
Yeah. No, sir. You answered it very well. Actually, like the investment in such kind of machines, I think depend on how you are trying to take your practice forward. What is the way that you are thinking? So I'll have Divakan sir. You wanted to discuss something about the camera and how to
Yes,
incorporate in your practice.
yes, I wanted you to give your inputs on how you screen your patients, number one. And number
Yeah.
two, I want the panel's opinion on, what should be the benchmark when one should acquire a ultra wide field system. Now, these are expensive systems, and, we can't charge that much to our patients for these, fundus images. So, when should one acquire it? And before, Nilesh, you can give your input how you screen your patients with these. You have Claris,
So
right?
Yes, I got Clarus, and how I use is a pretty absurd way. Actually, no, I don't think anybody is using like that. So what happens is any patient who gets registered in our center, it gets AR, NCT, and then a Clarus imaging done. The problem was we have a lot of OPD patients, and me and my father two physicians are here to cater to all patients. We don't have anybody else who is supporting us right now. So we wanted to have something which gives us a faster turnaround time and less because the waiting area is less and we had to cater to around 125 patients. So we got Clarus. So what happens is when patient comes to me, the fundus is already done. So I immediately counsel the patient. If there is cataract also, you see everything is blood. Tell them, see, this is your good eye where you can see your fundus clearly. This is the cataract which is clouding your vision. Get operated. If there is retinal pathology, I just tell them this is your pathology, get the OCT and everything. So they understand very quickly. My chair time becomes quite less, and the dilatation goes down. We obviously dilate the patients who actually require it, like high myopes, where I have any retinal pathology, or they're complaining of flashes, floaters. So all those we don't ignore, we diagnose them. So, but the 100% of patients who were getting dilated in our center, now it has come down to 20-25% in a day. So indirectly, it is generating us a revenue of around 20 to 25 OPD patients every day. So that way, we are recovering that Clarus cost. Otherwise, we would not have been able to because the direct, as Piyush told, in last 1 year, I think we have generated around 1.5 to 2 lakh through that machine, and we had paid an EMI more than that. Every month, we are paying the EMI for that. So that is one thing. So it depends on like what Pure Sir is telling, how you want to incorporate in your practice. I don't think anybody else is using it like this right now. Probably if somebody else sees the value, uh, they have waiting patient, it can be done.
So I was there in Stanford for some time, and this is what they did. They had, I think, California, machine with them, and so they did ultra wide field for all their patients. But they did OCTs for all their patients also. So a different protocol. But the panel's opinion, whether it can be utilized in this way, and again, at what point in our practice should we think about acquiring them?
Divakan, can I
I
just quickly add
feel
one thing?
Sure, sir. Sure, sir.
So I think this is excellent utilization of the machine by Nilesh. I mean, how do you utilize? Is the machine is yours? You can utilize it the way you want it. So if it has to be whether it's revenue generating or whether it's giving you satisfaction or you're making pictures doesn't really matter. It is something that is essential. No, I'm not talking about ultra wide field or wide field or conventional fundus photography, but a camera is essential. Now, I have a friend. He's when he's out with me in a conference, we're sitting and having a coffee, and he gets images from his staff who are taking pictures with his Claris. Just like you, I mentioned Claris because in his case it is a Claris. Another of my friend, it's another ultra wide Optos where they've picked up a break. The optometrist has picked up a break in the periphery, which otherwise would have gone missing. For especially single centers, single retina site surgeon centers. So again, there are so many ways that you can utilize those machines. If you have the moolah, there is nothing like an ultra wide machine today. However, even if you are, it's not just a return on investment. It's how many cases you miss otherwise if you are not there, if you don't have the time. Like you said, you brought it down from 100 to 20. That's a huge number. I personally would never want that in my practice because for me an indirect ophthalmoscopy is irreplaceable. No amount of imaging can give me what depression gives me. So again, the utilization is just so different and it's so unique. Anyways, coming back, please, the other panel and Divakant.
And Dr. Pranav, Dr. Shatish, your take on this?
I think Dr. Piyush sir has already summed it up very well. And ultra wide field imaging as of today is not indispensable in a practice where already a VR surgeon is working, because the kind of satisfaction that we get after having examined a patient through indirect ophthalmoscopy is unparalleled. And yes, in our absence, like the scenario Piyush sir presented, ultra wide field imaging does play a very critical role. But when we are there, so we would like to have each and every single patient gone through our examination through a 20D lens.
Yeah.
And if
Because
someone is
yeah,
if someone
so
is
there is a actually scientific logic that goes behind it. When you study the peripheral lesion, how many lesion you are going to actually miss when you are doing an ultra wide field imaging and indirect ophthalmoscopy. The correlation is there that you are not going to miss a significant number of clinically significant number of patients. There are multiple studies done on that, and that was the basis of me is and actually like when I started doing, I am feeling the same thing that I'm not missing many of the peripheral pathologies even while not dilating. So just Tivais's comment on that, and then Dr. Pranav's comment, and
Nilesh,
then we'll.
one quick comment before, sir,
Yes,
is
yes,
that
sir.
also depends. It's very difficult to compare how many lesions I personally we are going to miss or the machine is going to miss. The
Yeah,
reason being that it also depends on the time that we are going to give to the patient. If the time that we are going to give is 10 seconds or 5 seconds for peripheral examination in eye, you
yeah,
are going to miss things. So if we
yeah.
if you
Even
have
in
a heavy if you
That
have a heavy load,
agreed on that.
if you have a heavy
Agreed.
load, it is better to get an ultra
Yeah,
wide field system wherein you can review.
yeah,
see
That-
when
agreed.
I we were in Chitrakoot at that time also we had the same system and we had an Optos, but we also did the study, but we found that there are some sort of lesions that you tend to miss in these. Like examining the patient is always better, like after indentation. But obviously, ultra wide field for explaining to the patient about the lattices and the holes, that becomes better, and the patient is more compliant after that for laser treatment. So I think um, there are pros and cons to it, but obviously, if you have the money, then you should always go for an ultra wide field.
So, Tivais's comment on that, and sir, I'll ask you one added question to that because you have a system where there is true color and there is a pseudo color image, both ultra wide field. And what Pranav was saying, that you tend to miss few lesions in Optos because the color scheme is such. So, what is your take on that? In these different systems, which one you choose and why?
Yes, I agree. True colors are the best one. The only challenge I face that the area taken by that Mirante, that pseudo color system is much better. Mirante uses four lasers, so that pseudo color is nearer to true color images. So that is a better thing. But whenever we have little bit hazy media, something in the vitreous or some opacity, then the image gets blurred very easily in Mirante. While Claris takes very clear pictures even in relatively hazy media. So that is a better option. The only thing is that to take the picture from aura to aura, your technician needs to be very patient and he should capture actually all around and spend little more time. And although these are the non-mediatic camera, you should ideally to dilate patients to get a very good image, and the room should be made dark if possible to reduce the artifacts and glares and halo. So what I would say that if you have a decent patient, let's say 20 plus patients in OPD per day, and if you can afford, you must buy a good ultra wide field fundus camera. It is going to add value to your practice. Not only you would convince more patient, you would convert more patients to opt for surgery. Like in beginning time, you have seen nicely with indirect, and you have explained everything to the patient, but that may not, they may not go for surgery. But once you show them, then it is very likely that they are going to opt for the surgery. So not only direct revenue generation, it adds up to indirect revenue generation in your practice. And once you have such system and screening tools, you have done IO and then you have done wide field fundus photography, then definitely any one procedure, if there is certain percent of chance of missing some lesion, if you are doing two procedure for a same patient, then that chance would go down further. So your accuracy in practice, convincing the patient, converting more patient to opt for the procedure. For everything, ultra wide field is a must. I think if you can afford, if you have 20 plus patients, then you must go for. But to start with, you should buy OCT with at least central fundus photo. What I would suggest for retinal imaging. See, you can see now I am having three laser machines. But once when I started my retina practice, I had only one laser with LIO, and the same laser I used to take to the operation theater to do indo laser, and then bring to the OPD to do laser PRP, barrage, everything. And even I used to manage to do focal laser to some distant microaneurysm which are not nearer to fovea. I used to manage to do focal laser also with LIO. But once I had decent number of patients, then I went to buy two more laser machines. So it always you have to budget your things. If you have certain amount to spend on your in or invest on your equipments, then you must think that what is first necessary thing I should have, and then you can buy a good laser with LIO that solves the purpose for OT OPD. And once you are fine with that, I used to take that LIO in NICU also to do ROP lasers. So I use that laser left and right and heavily. But now I am having decent practice, so I have three different laser machines. So you can add any time, but at a starting time you should think that I have X amount of money, so I should buy this machine first. And once I am comfortable paying the EMIs, the loans and all, and repayment of the loans or recovery of the investment amount, then you can think of buying and adding those things. And you should actually plan your practice, and that scheme of acquiring instruments, that first line, second line, third line. Actually we did that on a start I would buy this machine, and once I'm comfortable and I can manage these instruments, I can pay out the EMI, then in the second phase I would buy these machines. And in the third phase, like I started with one constellation, now I am having two constellation, one centurion, and planning to buy another phaco machine so that we can cater the patients. But to start, you can manage with one single machine, and that can generate you enough uh, money so that you can add new and new machines and you can build your own practice. And once you add any good thing, that adds value to your practice, and that helps in many ways to grow your practice.
Nilesh, can
Thank
I
you
just
so much,
add
sir.
to
Actually, that
yours?
was, yes, sir. That was my last question. Actually, I wanted that to be the closing comment. I wanted to ask each one of the chairperson and panelists, which are the five OPD machine and three OT machines that you will buy at the start of your practice. Sir, Piyush, sir, your take on that, and then Dr. Pratik wanted to add something.
Five
Piyush, sir,
OPD
please.
machines and five.
And three OT machines that you want to start your practice with today.
Okay. But before I take that, I'd like to add to what SPT sir just mentioned. See, I mean, it's just phenomenal to hear of the armamentarium that he has. Like, we can probably get rid of all blindness in Maharashtra with his machines. But just because of his laser example, he started off with an LIO system, then went on to buy two more. My suggestion over here to a beginning retina surgeon is buy an integrated system. If you can't buy at that moment, wait 6 months, wait a year, wait 2 years if you have to, but buy an integrated system. The reason for that is, first of all, the number of PRPs have come down drastically. Uh, uh, Unless you are purely into an ROP practice, in that situation, perhaps it's advisable to get a LIO only. Otherwise, lasering on a slit lamp is far more comfortable for a patient as compared to an LIO, consumes less time. So I would say that buy an integrated system right at the onset. Now, coming back to your question, five machines. Okay, let me think. Of course, your slit lamp is included, I'm sure. Uh, I'm not even going to count indirect and the lenses as machines because that is an indispensable part. You can forget to buy a car, but you can't forget to buy or a bike, but you can't forget to buy that. Uh, I think for the OPD, perhaps this would be sufficient. Uh, I- uh, if you can add on then OCT, it's an excellent tool over there. AR, of course, you will have to buy no matter what, unless you decided to not to do AR at all and do purely retina practice. Then, of course, an ARK or an AR is going to be the next machine. That is, am I already at five? So
I think three.
slit lamp,
Slit
indirect.
lamp, OCT, and AR. No, indirect is not included. So indirect
Okay.
is like
So, so slit lamp, an ARK, an OCT machine, of course. I would also recommend to buy a fundus camera. It's extremely useful in counseling. Like SPT said, if it's difficult to buy a big machine, buy something smaller in the beginning. But if you can wait it out a little bit and buy something slightly better, then that would be a better option. I think with just four machines, you still have one machine of profit that is remaining. You can spend it on furniture and the other things. For OT, my first go-to would be have a good laminar flow OT. It's not a very expensive deal. It'll cost you just a 200 square feet or a 180 square feet OT space. You can get a good laminar system with paneling and everything done within 7 to 12 lakhs. So I think that is very important, more than the machine. I think that is more important for me. The second would be a microscope, of course. The third, of course, is going to be your vitrectomy or your since you gave me only three options, then it would be a vitrectomy or a phacoemulsification system. I'm not counting the instruments; they're not going to be the expensive part.
Yeah. Thank you, sir. Dr. Pratik, your take.
Yeah, so just a little observation, like all of the panelists and everybody has been just commenting that we need this, any machine would add value and this machine would help that. So what I've observed is like when I started my practice, a small room would fetch me a little amount of patients. As soon as I expanded it into a proper center, I started having a footfall of about 10 to 12 patients. And same happened with any kind of equipment that I acquired. Once I had my cataract machine, I started to have cataract patients coming in. Same happened with my vitrectomy machine. What I'm trying to emphasize here is that once you start, you actually start to get value and you start to get patients accordingly. And you can actually see that once you do that. So, and second thing regarding that ultra wide field camera, I feel if you can actually have it with an angiography, it's not only going to work out for just ROI. For patient perspective, these days we are actually focusing from PRP to a TRP thing. We are going to target retinal photocoagulation. So once you have a proper wide field angiography, you can only target the requisite areas and CNP areas only, even for diabetic retinopathy. So certain advancements in treatments will actually take us forward as an advanced medical community as well. So that is something that we need to keep in mind while we are investing in technology as we are actually growing up from 5 years or 10 years of practice. That is one thing that I just like to add.
Thank you. Dr. Pranav, your take, which machines you will start with your practice with?
I think slit lamp, an OCT, a laser machine, an OCT, an AR, and NCT machine. That would be just for the OPD. And for the OT, I think a machine, obviously the Retina machine, Constellation or Reticare, any one of them, and a microscope with a good microscope with a biome or a resight if I can afford that, and a phaco machine because I do phacos also. But
Okay.
I would
So two
prefer
machines
keeping it
rather than
separate.
one.
Yeah, yeah.
Yeah.
I would
Uh,
prefer keeping it separate.
Okay. Dr. Kshitij, same in OPD, or you want to add B scan instead of anything?
I don't still have a B scan at my center because there's a radiologist right in front of our center and we share a very good camaraderie. But I began my practice with the FFA unit and we have that of Remedio. I don't think so. It is still in the market. They have discontinued it. It came by the name of AOT, NGO on Touch, and it was a very economic investment with excellent picture quality, excellent results. And we are still quite satisfied with the FFA pictures that Remedio is giving. And considering the other alternatives in the market at that point of time, there was a substantial price difference. But alas, it has been discontinued. The rest all remains the same as Dr. Pranav and Dr. Piyush mentioned.
Thank you. Thank you. SPT sir, your list is same. What everybody else has told.
ARNCT slit lamp is must, and then one laser, one OCT, and one USG B scan, A scan combined machine should do in the OPD. For OT, you should have one microscope and viewing system, and a combined phaco and vitrectomy machine. That is at least required. Apart from that, all those microsurgical instruments and all that that are well understood, that those are actually required to, like autoclave and then those cryo machine. These things are, we are not counting. These are understood things.
Thank you so much, sir. I think with that, the discussion has been really great. I think it was very pertinent to all the general ophthalmologists and young ophthalmologists who are going to start their practice. Thank you, Sunandari ma'am, for allowing me to hog all the limelight. It was my what you call lalach, because Tiwari sir is my mentor. He has trained me in retina, so I just wanted to have this chance to interact as much as possible in this during this webinar. Thank you, Team Career Portal, for having continuously having this. And I would also like to invite. Actually, the personal invite will go to everyone, but I think I'll take this opportunity to invite Dr. Piyush sir, Dr. S.P. Tiwari sir, and all the panelists and the speakers to YOSICon. That is our annual conference at 5th to 7th September at India Habitat Center, New Delhi. We would love to have, because we are going to have for the very first time, sir, we are going to have fellowship and job mela. So we have onboarded many big chains like ASG is on board, Sharpsight is on board. I think Max Vision is on board, Swan Jyoti is on board. There are multiple chains that are on board, and they are on site going to conduct interviews of young ophthalmologists and offer them fellowships or job, whatever is required at that point, sir. So we would love to have you to be a part of that conference and share your expertise in life, sir. Thank you so much.
Thank you.
Thank
Thank
you
you.
so much, everybody.
Thank you so much.
Good night. Good
Thank
night,
you.
everyone.
Good
Good
night.
night.
Good night. Thank
Good night.
you. Thank
Bye.
you so
Bye.
much.
Good night, sir. Bye.